Today's video, we're going over shoulder instability, exercise basics. So the first key of treating folks with shoulder instability is knowing the direction of instability. So if I have a patient who got their arm ripped behind them in this direction, chances are the ball moved forward in the socket. The large majority of shoulder dislocations are going to occur anteriorly. And here's the thing, you have to know a little bit about joint arthrokinematics to understand this a little more fully. So when I go into end range abduction, so bring my arm way out to the side, horizontal abduction, external rotation, as well as extension of the shoulder joint, the ball moves anteriorly, right? Now this is not a video about diagnosis. I actually have that video. I'll leave a link in the show notes in the description if you guys want to check that out. But when I move into these directions here, the ball moves anteriorly. So I have a patient that has apprehension in those positions, two things. A, early on in rehab, I want to make sure I avoid those positions. I don't want to create a subluxation or dislocation. And later on in rehab, I want to make sure I really stabilize those positions as much as possible. If I have someone who has posterior instability, the movements that make the ball move posteriorly or backwards in the socket are going to be horizontal adduction, flexion, as well as internal rotation. So if a patient has posterior instability, early on, I probably want to avoid those positions, but later on in rehab, I need to really hammer them and get them stable, especially if their sport is going to require going into those positions. Second principle is the importance of the rotator cuff. So in the shoulder, you have a couple different restraints to motion. So the first of which is going to be the shoulder capsule, right? So the series of ligaments that go around the shoulder joint, as well as the labrum. On top of that, you have the rotator cuff that kind of hugs the ball into the socket and provides stability. Now, if I tear one of these ligaments fully or if a lot of laxity in one direction, then my primary restraint is going to be the rotator cuff. So it's important in shoulder instability that you focus a bit on the rotator cuff. The other piece is that the diagnosis is also important. So if I have someone who has anterior instability, so the ball is moving forward too much in the socket, causing apprehension, the primary restraint to the ball moving forward is going to be the posterior cuff. So the infraspinatus is very, very important in folks that have anterior instability. Now in someone that has the opposite problem, so posterior instability, the ball is going to be moving more posteriorly, the anterior cuff becomes much more important because the anterior cuff, when it fires, it pulls the ball back in the socket, right? So if you have a patient that has shoulder instability, obviously you want to train the whole shoulder. The other piece, we probably want to zoom in on those particular muscles that serve as a restraint for the ligament that's lacking or lax. So I know these exercises are super boring. I kind of hate giving them to my patients, but you really should in the early stages of rehab. Some simple ones you can do for folks that have anterior instability. So when the ball is moving too much forward in the socket, we need that posterior cuff like the infraspinatus in order to pull that ball back. It's just a basic dumbbell sideline external rotation. So we have scat here, elbow glued to the side, hand starts on the belly and just rotate up towards my hand and right back down again. All right, super simple, super easy. The other one I like to start my patients with, let's have you go ahead and stand up here, Scat, is going to be good old scaption. So essentially we have Scat standing here, we have a dumbbell in her hand, thumb is facing up, and as she lifts to her side, she's not gonna be directly to the side. You can relax for now. She's not gonna be here, she's not gonna be here, she's gonna be in the scapular plane, about 30 degrees off of the frontal plane here, and performing basically abduction with the thumb up, scaption. Basic rotator cuff exercise, works the top of the cuff, but also the back of the cuff, which is really important. For folks that have more posterior instability, you want to focus a bit more on the subscapularis. A couple easy ones you can start with is a basic internal rotation against band resistance. Let's have you do a few here, right? Piece of cake. The other thing we can do is go into varying degrees of abduction. So let's go ahead into about 45 degrees of abduction and externally rotate for me. And then go ahead and do a few reps here. Excellent. Obviously, you wouldn't have the therapist holding the band here. I'm just trying to demonstrate this for you guys. And then we can also go into a 90-90 position and come straight down. Go ahead and come down, perform a few reps. And just to keep in mind, if you have posterior instability, this position usually doesn't feel unstable. For anterior instability, it does. So you can probably start in more abduction, external rotation for posterior instability, but I wouldn't start there for anterior instability.
To go along with the video today, I have a little gift for you. It's an evidence-based cheat sheet for shoulder instability. It's a 4-page PDF that goes over everything you need to know about shoulder instability. We go over prevalence, anatomy, joint arthrokinematics, risk factors, and different types of instability, causes of instability, whether or not your patient should undergo surgery or have conservative care like physical therapy, and finally, rehab implications for all the different types of instability. So if you're looking to get up to speed about shoulder instability in less than 10 minutes, then this PDF is for you. I'll leave a link in the show notes in the description. Go ahead and click on that and then download it and then get back to what you're learning about right now.
Next principle we're going to focus on is using closed chain exercises. So if I'm doing a push-up, my hands are fixed to the floor, my torso is moving, this would be a closed chains exercise. If on my back doing a bench press, I'm moving the bar while my torso is fixed in place, that's going to be open chain exercise. Now why would we choose closed chain over open chain? Generally speaking, when we do closed chain exercise, we have a good co-contraction of all the muscles that surround the shoulder joint. This provides a lot of stability, so folks have a lot of apprehension, especially early on with their rehabilitation. It feels quite stable and they can tolerate quite more of these closed chains exercises compared to open chain normally. The other piece, if you start looking through the research on some of our closed chain exercises, we're just really hitting a lot of these muscles. So we have high EMG of a lot of the musculature around the shoulder, so you might be getting a little more bang for your buck by choosing them. Now, probably the first and the easiest closed chain exercise I like to do with my patients that have instability is going to be a good old plank. Usually we start in a push-up position, and we also usually start a little bit elevated. So if I start an elevated surface with my arms straight, that's going to be a little bit easier than going closer and closer to the floor. So as people progress, it's very easy to start in a plank position with the arms straight. Let's go ahead down to a plank onto the elbows here, Scap. So now we're getting a little bit closer to the floor, and if we go all the way down on the floor, it's even harder. And you can go ahead and stand up here, Scap. One thing to think about is that with posterior instability patients, we talked about arm across the body and internal rotation, pushing that ball posteriorly in the socket. The other thing to keep your eye on is when you do a push-up or in your plank position, basically gravity is going to be forcing my torso forward and pushing the ball posteriorly in the socket. So these axial loads in a plank position can sometimes be very challenging for patients with posterior instability, and it's actually a contraindication for your post-op patients to have their posterior labrum repaired early on. So just keep that in mind. If it's tolerated well, great, but I would just go slow and progressive for posterior instability patients. Just keep in mind that can also create some issues. So once you get your plank down, there's a few variations I like to try. We're gonna have Scat go ahead into our push-up position again. And the first thing we're gonna do is going to be a plank plus. So we're literally doing a serratus punch with both arms straight. I cue my patients to relax through their shoulder blades so the torso is sinking through the shoulder blades and pushing away as much as possible, just like so, okay? Another drill I like, in this same position, we're going to take the feet a little bit wider just to provide some stability. I want you to shift towards one arm and tap the opposite side shoulder. Yep, we'll go back and forth. My cue for this is also to push through the shoulder blades, and I like to pretend like there's a glass of water in your lower back and you're not trying your best not to spill it. If this is tolerated well, we go into a plank turn. So essentially, both arms are going to be down on the bench, and we rotate and push away from the bench. Can you show me a few of these, Scat? Excellent, good job. Yep, Scat's doing a great job. When you go slow and controlled, what you may find, particularly with those anterior instability patients, as we go towards end range of motion, out through here, we're getting into horizontal abduction. So early on, you might have to cut that range, but later on, you probably want to make sure you promote that range of motion. We can also spruce up our normal scapular exercises by adding a little bit of closed chain stability on one arm. So we're gonna have Scat here, and she's going to post on one side. Think about a dumbbell single arm row. However, her legs are extended out a little bit more. And what's happening now is that she has to provide stability on her left side shoulder while she moves through the right side. We're gonna do a prone extension or a dumbbell A, so Scat's just moving, getting good scapular stability by performing the prone extension. She's also pushing on her left side arm here and strengthening all the muscle around the shoulder. So this is nice because we're being efficient with our time. We're getting good closed chain stability on one arm, stand side arm, while we're getting some strengthening on the opposite side. Get a lot of bang for your buck. You can take a breather for now, Scat. If we want to make this more challenging, we can quite simply go into more of a plank position. So if I'm starting off in that bear position like you saw, we can just straighten out the body like so. Do you mind showing me that, Scat, just so everyone can see? Yep. So we're starting off, yep, and then we go straight into a regular plank position. And just like we made the closed chain exercises harder like the plank, we can start working our way down to the floor, and this is gonna make it harder and harder on the stand side arm. You can also increase the challenge at the shoulder in a closed chain fashion by doing side plank variations. And I like to start on the knees just because it's a little bit easier than leg straight, but obviously you can work towards leg straight over the course of time. So Scat's in a half side plank position. Let's have you pop right up. My cue is to try to push down into the floor, so we're actively trying to push the floor away. Keep in mind the position that the shoulder's in. If you have someone who has anterior instability, we're going into horizontal abduction. You have to be careful it doesn't cause a bunch of symptoms. But the other thing about this position is that the ball is being pushed directly into the socket. So usually it's tolerated pretty well, but if it's not, obviously modify it or don't use it. And then from here, the top side arm can get busy and do some fun exercises. So Scat's going to grab onto her dumbbell. She's gonna glue her elbow to the side and perform a few external rotation, right? So you'll be a little more effective. Again, stance side stability and some strengthening on the top side arm. You can also do something like a scaption. So let's go straight arm scat, thumb towards the ceiling, and just lift it up to about shoulder level and right back down again. So you can get creative, and we can get some stability on both side arms at the same time, a little bit more bang for your buck. The next important principle is to incorporate compound movements as soon as it's tolerated well by the patient. Now, what does that mean? Compound movements work multiple muscles, multiple joints. Think about the difference between a bench press and something like a tricep extension. Tricep extension, we're isolating the tricep. We do a bench press, we're working tricep, delts, pec, a lot of stuff going on. And there's a lot of bang for your buck for these exercises, and usually it's going to be a little bit more functional, and or a lot of your patients might be trying to get back to something like bench press. So a lot of birds with one stone by using a compound exercise. The other piece is that when you're doing something like a bench press, of course you're still using your rotator cuff, and you could argue that you're using your rotator cuff in a more functional manner, right? So if I have a patient that has a lot of anterior instability, and I'm trying to target the posterior cuff, if I do a lot of pressing, infraspinatus or posterior cuff is very, very active when I press. If I have someone that has more posterior instability, and I want that subscapularis to be strengthened and do some good work, I might prescribe some rowing exercises like a TRX row, because I know that we're strengthening a lot of muscles, A, but B, we're also targeting the subscapularis in a functional way. One of the first exercises from a pressing perspective I love to incorporate with my patients early on in their care is going to be a dumbbell floor press. Now, the floor press is really nice because it eliminates the range of motion down here. So if I have someone that has anterior instability, oftentimes that end range of motion is not tolerated well, but if we just cut that range of motion out by adding the floor, then we do quite well. So let's have scat here, show a few repetitions. Now, in terms of your positioning, go ahead and press out for me, and then finish with your hands right over your shoulders. You got it, good. And right back down again. So we can be a little variable with our elbow position. So if I have my elbows a little closer to my side, this is probably gonna be a little easier on the anterior structure of the shoulder as opposed to going out wide this way, because I'm a more horizontal abduction. So if someone has apprehension, you maybe want to start them here, and over the course of time go a little bit wider. And as your patient improves over the course of time, obviously we can just go to a regular bench. I'm also a big fan of doing cable pressing. A couple of reasons for this. So A, when you're pressing from a cable, it's actually a little bit unstable. It wobbles around a little bit, makes the muscles around the shoulder joint maybe work a little bit more. The other reason why I like it is because when you're doing a cable press, you're also limited by your core. So essentially, you have to stabilize with your core to even get into this position. So oftentimes your athletes have to reduce the load early on just because it's an unstable movement, your core has to work. Early on in rehab, usually heavy loads don't feel great, so this is actually a really nice variation to start with. I also like to try to use a partial range to start, but obviously over the course of time, as your athlete is able to tolerate this, we can go into deeper ranges of extension. So Scat, let's have you grab the cable here and just show everyone what I'm talking about. Good, you got it. We'll do a few repetitions. We press out fully and reach. I like to get that extra punch at the end, right? Yep, stopping at about shoulder level and then reaching again. Yep, looks great to me. Another reason I really like the single arm cable press is because your patient generally has the other arm free. And while the other arm is free, feel free to take out your phone, bring up this video, have them hit the like button, and then definitely subscribe to the channel. Keep pressing. Yep, other side arm too. The last pressing variation I like to start with is going to be a good old push-up. Now, normally I'm starting a little bit elevated unless you have an athlete that's either A, super strong, or B, not irritable at all, right? I start a little inclined, and obviously as I get stronger, we work back to the floor. Reasons why I like this: A, it's a closed chain exercise, which is really nice. B, it's usually an easy movement that most folks are used to, so it's a nice starting place. The other thing to keep in mind is that this is not a unilateral exercise, so in some folks you're going to see a lot of compensation. And if they just compensate so much because they're very painful or apprehension, might not be the best starting place. But let's show the push-up right now, Scat. Very good, so hands are going to be on the bench. From here, good posture. Go ahead down, try to touch your chest down to the bench. Yep, and pressing away. Try not to have your head come forward as you're going. Yep, good alignment. And at the very top of the motion, I like to cue that push away, get the extra serratus anterior punch at the very top. Great job, Scat. In terms of rowing exercise, you have a lot of really good choices, and this is completely anecdotal, but I find that most folks have either A, shoulder instability, but also general shoulder pain. Usually rowing is tolerated really well when you have an injury, whereas pressing is going to be the more complicated one that you might have to back off of initially. If that's the case, obviously, then you can do a little less pressing or reduce the intensity of the pressing and just really do a lot of rowing, which is going to be very beneficial for the shoulder. So one of my favorite exercises is going to be a dumbbell single arm row, and it's for two reasons. So for one, we have good stance side stability. So when we do a dumbbell single arm row, we're really thinking a lot about the rowing side arm. The other piece is that the stance side arm, so the hand that's on the bench, is actually pushing pretty aggressively to make sure you're not rotating too much through your core and your trunk. So let's have Scat do a few repetitions here. Yep, she's got one knee on the bench, one hand on the bench there. She's reaching down towards the floor. She's rowing straight up to her ribs. Good posture. Looks excellent here, Scat. Another great rowing exercise to start with your patients is going to be a TRX row. So this is a TRX strap. It's attached here to a pull-up attachment. Most gyms generally have this, and if you don't have this at your PT facility, I'd say it's worth, spending a couple bucks on getting it. But this is great because it is also a closed chain exercise, meaning that the hands are fixed and the body is moving, which again, we're getting that great co-contraction. The other thing is it is super simple to make it easier or harder. All you have to do is move your feet forward or backwards. When you have someone that has shoulder pain, if you're trying to use different dumbbells, slinging heavier or lighter dumbbells around, sometimes the act of moving the dumbbells is really challenging on the shoulder. For the TRX, it's very, very easy to make this easier or harder. No stress on the shoulder at all. So for Scat here, we're gonna have her walk her feet in just a little bit. She's going to keep good posture, so think about staying tall and falling backwards and controlling that motion with her arms. I like to add a little reach at the end, so I like to get some protraction, use those shoulder blades, then pull all the way up, pulling the hands to the ribs. Yep, trying your best not to shrug your shoulders up to your ears, so shoulders more down, retract the shoulder blades, and then reach all the way back to your starting position, just like so. Yep, looking great, Scat. And if we wanna make this harder, let's take your feet and come in a few inches. Yep, let's do 1 or 2 reps. Yep, piece of cake. It starts to get more challenging. I see a little sweat forming on Scat's brow. And if you wanna make it easier, all you have to do is back up a few inches. So show us that real quick. Yep, so very, very simple and easy to make this harder or easier for your patients. Another way we can make exercise more beneficial for unstable shoulders is by adding an element of proprioception. So if you think about folks that sprain their ankles, we do a lot of single-legged balance exercises. We're trying to restore proprioception of that ankle. Well, when you have anterior instability, posterior instability, multi-directional instability, you lose some of the proprioception within the ligaments of the shoulder based on the injury. So we're trying to restore that. And there's a few ways to do that. So for one, you can use unstable objects, like a bottoms-up kettlebell press. You can also do plank exercise on unstable surfaces, just like you would do for single-legged balance. You can also use rhythmic stabilizations, which I'm gonna make another video about that, so stay tuned for that one. And the last piece we can do is close our eyes during exercise. So normally when we're trying to get feedback about where our body is in space, we have 3 different systems that give that as information. So for one, you have the semicircular canals within your head. So if I close my eyes and start moving my head around, I know where my head is in space because I'm getting feedback from that system. I also get feedback from my eyeballs. So essentially I can see where things are and that gives me feedback. The last piece is we have proprioception, or little kind of feelers, receptors within our body that give us feedback about where our body is in place, or excuse me, in space. And when I have, let's say, a dislocation or some sort of instability, I lose that proprioception. So I'm trying to restore some of that. And if I close my eyes while I'm doing exercises, helps to restore the proprioception within the joint, so I'm taking away the feedback from my eyeballs. So one unstable surface I like to use is a rocker board, right? So you can see this goes side to side quite a bit. So what we can do is we can have our patient here, Scat, with shoulder instability, just perform a plank holding on the sides of this object here, right? And as you can see, it's a little bit unstable. So there is some challenge within the shoulder joint. The next thing we can do, if this is too easy, is promote a little bit of side-to-side motion. So you're trying to tap one side of the rocker board to the floor and the other side just like so. Excellent job. We're gonna move this out of the way and we're gonna throw the Bosu ball in here. So Bosu ball gives you more degrees of freedom. So what we'll try is go ahead and plank and hold on to the sides for me. So the first thing we'll do is the same exact side-to-side weight shifting, trying to tap the outside and then the other side. Yep, back and forth, very good. The other thing we can do here is try to draw a circle. So essentially trying to get the rim, yep, and going all around the rim of the Bosu ball. Let's go ahead the other direction. You can see it's actually pretty challenging. So a good way to challenge your patients to have anterior instability. We can also provide an unstable surface with medicine balls. I would just proceed with caution. These are quite a bit more challenging than the rocker board variations. And where we're gonna start, at least for this video today, is gonna be on your knees. So you're gonna have your patient actually start in quadruped with both hands on these balls right here. and you can perform a variety of movements. If we want to make this more challenging, we just weight bear a little bit more onto the balls. If we want to make it easier, we go the opposite direction and just weight bear a little more to the knees, right? The first thing we'll try is just going forward and backwards, kind of a sawing motion, just like so. You can also try side to side with the hands. Excellent. And you can also do some circles. Yep, you can go clockwise, you can also mess around and go counterclockwise. Now, I'm not gonna make Scat do this, but if we wanna make this more challenging, all we have to do is pick up the knees, and eventually we can go fully out this way. That, again, is gonna be quite a bit harder. Plus, you don't wanna dislocate your shoulder trying to rehab your patient, so proceed with caution, right? All right, so we can also challenge the shoulder by using an unstable object, something like a kettlebell bottoms up. So when you have the kettlebell facing upwards, it's gonna wiggle around. You have to use your shoulder and your grip to really control that. So we get some good stability within the shoulder joint just from choosing this implement, okay? The first exercise we'll do is just a basic press. So essentially, Scat's allowing your elbow to touch the floor, then reaching up towards the ceiling. At the very top of the range of motion, just make sure that kettlebell is directly over top of the shoulder. Excellent, good job. Next one, bring that arm fully locked out. Let's do a serratus punch. So elbows locked out, just reaching up to the ceiling, and then relaxing the shoulder back down onto the floor, and then reaching back up again. Excellent. Next thing we can try is something called a screwdriver. So pretend like you have a screwdriver and you're trying to screw in a screw, fully forward, fully backwards. The screw's just gonna stay right there in place, but the shoulder's gonna be super strong, right? Excellent, good job. And the last thing we can try is going to be an arm bar. Now be a little careful if you have someone who has anterior instability. We are going into horizontal abduction, so don't dislocate a shoulder, right? But it is a good exercise to do. You need to cut the range of motion early on, then definitely do that. So go ahead and press up to the ceiling here. Excellent. And what we're going to do is have the right side foot up, so the same side that has the weight, and the left side leg is going to be straight. The heel is going to be closer to the hip and actually out to the side a little bit. You're going to drive with your hip by pressing the foot into the floor as you turn from the upper body as well, and you keep that kettlebell over top of the shoulder the entire time. Let's try a rep or two here, Scat. Yep, and reaching up to the ceiling, kettlebell stays directly over top of the shoulder the entire time. Right. And the other thing is, if we want to make this harder, all we do is add some more weight. We can also go a little faster, go a little further in terms of range of motion, and we can also close those eyeballs, which makes things much more tougher. So now you're an expert with some treatment ideas for shoulder instability. You still need to know that you're treating the right type of instability. So I have a video for you. I'm going to leave a link in the corner. We'll go over the diagnosis, starting with anterior instability, so you know what to avoid early on and what you know what to progress to over the course of time. Click on that link, and I'll see you in that video.